Hello, everyone. Thank you for joining us as we are now going to start today's webinar on research methods for studying the primary care workforce. Before we begin, I'd like to go over a few WebEx logistics. To ensure audio quality for all attendees, we have muted everyone's lines. That means you can hear us, but we cannot hear you. Even though your lines are muted, we do want to hear your questions. To ask a question, use the chat feature that is located on the right-hand side of your screen. You may have to click the arrow next to it to expand the section. You'll be able to send your questions or comments to all panelists and to everyone within the chat feature. We will answer all questions at the end of the presentation. And now I will turn it over to Amy Eden to start the webinar off.
Thanks, Miriam. All right, welcome everyone. We are really happy that you could join us today. My name is Amy Eden. I'm the acting director of AHRQ's National Center for Excellence in Primary Care Research, or NCEPCR. And it's really my pleasure to welcome you and our presenters to today's webinar. Before we jump in, get started with these really great presentations, I just wanted to start with a few words of introduction. Next, hold on, my laggy thing, next slide. So AHRQ's 1999 authorizing legislation that established the federal government's only Center for Primary Care Research included language suggesting the importance of research on the primary care workforce, which really underlies the nature and the characteristics of primary care practice. Next slide. And today, our NCEPCR vision includes a healthy primary care workforce. The mission of improving the delivery of primary care really can't be achieved without understanding the many challenges facing the primary care workforce, as well as optimal primary care workforce configurations and structures that are positioned to deliver high quality primary care. Next slide. So AHRQ has a long history of funding work around the primary care workforce. I don't have time and I won't describe all of that now, but I did want to highlight a recent article by AHRQ colleagues that presents and applies a novel and pragmatic approach to refine how we identify and count the primary care workforce. The framework includes not just clinicians from primary care medical specialties and nurse practitioners and physician assistants, but also the practice setting in which they work and the types of services they provide. And I would encourage you all to check out the article if you're interested. Next slide. I also wanted to mention our new R01 primary care funding opportunity that was just released at the end of March. While it is a very broad notice looking for primary care research kind of across all of the different areas, given today's webinar topic, I thought I would just highlight and point out that primary care workforce related topics are included in the scope, and we really welcome research around all the different ways that the primary care workforce is important. And next slide. Finally, I just wanted to share this opportunity that came across my radar. No way is AHRQ affiliated with it, but timely call for papers for a special issue on the primary care workforce in the journal Family Practice, which comes from Oxford Press. Next slide. All right, so today's webinar has a primary objective of highlighting examples of research methods used to study aspects of the primary care workforce. We'll get to learn about nurse practitioners as an important part of the primary care workforce and about ways to think about how primary care teams function and how they're structured to impact cost and quality of primary care. Next slide. And now, without further ado, I'm really honored to welcome our moderator for today's webinar, Dr. Yalda Jabarpour, who is the director of the Robert Graham Center. She'll be facilitating the presenters, and also the Q&A and discussion, which, like Miriam said, will take place after all of the presentations are finished. So with that, I'm going to turn it over to Yalda. Welcome and thanks.
Thank you, Dr. Eden. It's a pleasure to be here with all of you. As Amy mentioned, I am the director of the Robert Graham Center for Policy Studies in Primary Care in Washington, D.C., and I'm also a practicing family physician, so I'm really excited to be hearing a lot of these presentations today. Today we have 3 primary care researchers here to discuss their research methods for studying the optimal structure of the primary care workforce and the role of nurse practitioners in improving access to primary care. So join me in welcoming Dr. Hannah Neprash from the University of Minnesota School of Public Health, the Division of Health Policy and Management. Dr. Neprash will be presenting on the role of nurse practitioners in improving access to primary care. Then we'll have Dr. Lawrence Casalino from Weill Cornell Medical College Department of Population Health Sciences. Dr. Casalino will be presenting on primary care physician staff Dyads or Teamlets, a simple, efficient means to improve healthcare quality and decrease cost. And finally, we'll have Dr. Sylvia Hysong from Baylor College School of Medicine presenting on the impact of team configuration and team stability on primary care quality. Before we get started, be sure to save your questions. We'll have the Q&A session after all the presenters are over. You can also pop your questions into the chat throughout the webinar for later if you'd like. And without further ado, I'd like to welcome our first presenter, Dr. Hannah Neprash from the University of Minnesota. Dr. Neprash.
Thank you so much, Yalda. So today I am presenting findings from an AHRQ-funded RO3 that is joint with my wonderful colleague Hillary Barnes of Widener University, and our project is entitled The Role of Nurse Practitioners in Improving Access to Primary Care. Next slide, please. So as background, we know that primary care physicians and nurse practitioners increasingly work together. At present, an estimated 1 in 3 primary care practices employs both of these types of clinicians, and you can see in the chart on the right-hand slide of part of this slide that number has really increased over the past decade. This is relevant for access to care because existing research tells us that nurse practitioners are more likely to treat historically underserved patient populations, such as patients of color, patients who don't have a source of insurance, and patients who are primarily covered by Medicaid. Therefore, interdisciplinary staffing and the rise of this team structure of primary care physician practices may expand access to care, especially for these historically underserved patient populations. Next slide, please. So in this project, we ask the following research question. When primary care practices employ nurse practitioners for the first time, how does access to care change, particularly for new patients, especially those who identify as individuals of color, uninsured, or patients with Medicaid coverage, and also for established patients at that practice? This study contributes to the literature, I think, in 2 main ways. The first is that we use a few relatively novel objective measures of access to care that I will tell you about very shortly. And we also use an all-payer data set that allows us to study access, particularly for a subset of AHRQ's priority patient populations. Next slide, please. All right, so speaking of data, we use data from Athena Health, which is a company in Watertown, Massachusetts that does really 3 things for their clients who are physician practices. They provide a medical billing service, they provide an electronic health record, and practice management software. So the data elements we're using come from all 3 of those. We have all-payer data from Athena Health from 2011 through 2017. And I want to highlight 2 particular features of the Athena Health data set that make our project doable. The first is that Athena Health really allows us to distinguish between rendering and billing providers for any particular visit. This is particularly important when you're studying any sort of activity of advanced practice clinicians, but nurse practitioners, of course, fall into that category because they frequently bill Medicare under physician IDs. This is a practice that's called incident to billing, and it means that it's very hard to see what nurse practitioners do when you're just using traditional sources of claims data. So the Athena data are very cool because they allow us to distinguish between who provided the care and who billed for it. And of course, those are not always the same. Second, the Athena Health data include practice identifiers. So really good identifiers to understand who is working together in the same clinic in the same location. And how does that change over time? So I want to fully acknowledge that the Athena Health data represent a convenience sample, right? We only have the practices that choose to work with Athena Health. And on the right-hand side of this slide, I show you some hopefully convincing evidence that this is actually a pretty generalizable sample. It's about 5% of all primary care practices in the US, at least during this particular study period. And when we compare the characteristics, both of visits and patients, between Athena Health and the National Ambulatory Medical Care Survey, we find broadly similar trends. Next slide, please. So our dependent variables fall into two main categories: access to care and convenience of care. Under access to care, we count the number of visits provided to new patients rather than established patients. And we do this using particular service codes that are reserved for patients that don't have a relationship with the clinician already. We also count the number of visits provided to patients who self-identify as individuals of color, visits for uninsured patients, and visits for patients where Medicaid is their primary source of health insurance. Finally, as a measure of access to care, we can quantify the number of days that pass between when a patient schedules a visit and when they actually receive care. Under convenience of care, we measure two things. We measure the number of visits provided on a walk-in or same-day visit, and we see these as visits where they're scheduled on the same day that they occur. That's how we define a walk-in visit. We can also observe visits that are occurring after hours. So that means any visit that happens on a Saturday or a Sunday, and also visits that happen outside of the standard 8 a.m. to 5 p.m. business hours. These last three measures here, average visit wait time and walk-in and after hours visits, are only possible in our data set because we have access to this scheduling information. So that's a very cool and somewhat novel feature. Next slide, please. So we are using here an event study framework. So we're defining our treatment practices as those that hire a nurse practitioner anytime from 2011 through 2017. Control practices are primary care practices that either never employ an NP during our study period or always do. The observations are constructed at the practice month level, and we include only practices where we have at least 12 months of data for them so that we have a decent pre and post period. This is our event study estimating equation. I won't go through it too much, but I want to highlight a couple of things. The first is that we have practice fixed effects that control for any sort of time invariant differences between practices that do and do not hire NPs. We also have some time varying practice characteristics. In particular, we control for the number of non-NP clinicians working at a practice so that we're not picking up effects driven by changes in the number of doctors or the number of PAs that work at that practice. Finally, we have month and year fixed effects to make sure that we are taking out any sort of seasonal variation and also controlling for time trends that affect all practices. Next slide, please. Okay, so now we jump into some visits, some results on visit count. So we find that overall practices provide more visits after they hire an NP. What I show you here, three versions of a very similar graph, showing estimates of the difference between the treatment and control groups relative to the month immediately prior to NP hiring. So I want to point out first that visit count evolves very similarly for treatment and control practices before they hire an NP. That's very reassuring from an econometric standpoint. After that NP is hired, we see an immediate change for treatment practices. We see an increase in visit count immediately, and it plateaus and stabilizes at about 103 additional visits at that practice per month. We can decompose that and look at who is providing those visits. And for the most part, the visits are provided by the new NP, but we also see that physicians at that practice are providing an additional 25 visits per month. I think this is a particularly intriguing result. It suggests that NPs free up physicians to provide more care to patients, but we don't yet know how or why. Next slide, please. So now we look specifically at visits provided to new patients. And here we also see an increase, but it's smaller. We see that after a practice hires an NP, they provide about 9 additional visits to new patients. Most of those are provided by NPs themselves, but physicians are seeing about 1 additional new patient per month after their practice hires an NP. Next slide, please. So on the left, we find that visits for Medicaid and uninsured patients go up by about 22 per month after a primary care practice hires an NP. And we see an additional 10 visits provided to Black patients out of a primary care practice after hiring an NP. When we look at this access expansion, however, we also we find that it's proportional to the overall visit increase. So another way of saying that is that the share of visits provided to these particular patient populations does not change, even though there are more of them altogether. Next slide, please. All right, so now we have findings for those measures of care convenience. Again, the measures are the number of walk-in visits and the number of visits provided outside of normal business hours. And we do find an increase in both of those, but particularly an increase in the number of walk-in visits. So these are same-day visits where the patient called and scheduled a visit, and that visit actually happened on the same day. We find an increase of about just under 50, and also an increase, but a smaller increase in the number of after-hours visits that are happening. These more convenient visits that align with patient preferences are almost entirely provided by nurse practitioners. We do not see that physicians are increasing the number of either walk-in visits or after-hours visits that they're providing after their practice hires an NP. So it's really the NP that is driving an increase in the convenience of care offered at that practice. Next slide, please. 3 main lessons learned for us here. We find that as primary care practices increasingly hire NPs, access to care expands. On average, hiring an NP means an additional 103 visits at that practice per month, 9 new patient visits, 10 visits for Black patients, 22 additional visits for uninsured and Medicaid patients per month, on top of what they were already doing. We also find that NPs improve the convenience of care as measured by more walk-in visits and more after-hours visits. Next slide, please. So as with most research, our findings raise more questions than they answer. I want to highlight 3 questions in particular. I'm so curious, what is it about interdisciplinary practice that enables physicians to provide more visits after their practice hires an NP? I'm hoping that we can use some electronic health record data to dig more into who's doing what and how does it increase physician productivity as well. Second, are these access expansions driven by patient preferences or by practice economics? So it's possible that certain patients prefer to see NPs rather than physicians. But there are also some differences in the practice economics here. Specifically, the one that I think may be driving certain decisions is that on average, it is the salaries of NPs are lower than the salaries of physicians. So that may drive certain workload allocation decisions at a practice. And then finally, the most important question here, I think, to answer, is this expanded access to care associated with changes either in the care quality itself or changes in health outcomes for the patients who are treated at that primary care practice? So thank you very much. I will stop here, and I look forward to hearing from the other panelists and to answering questions at the end.
Thank you, Dr. Neprash. That was excellent. We've got some great questions coming in, so keep those questions coming. Next, we have a presentation by Dr. Lawrence Casalino on primary care physician staff Dyads or Teamlets. Welcome, Dr. Casalino.
Thanks, Yalda. Nice to follow such a terrific presentation by Hannah, really exemplary. And also, I got the findings that I assumed that she was hoping to get. I wish I could say the same for this study of Teamlets, and I'll say more about that in a minute. Next slide, please. So thanks to AHRQ for funding, and this was a big team and a lot of work. This project, great team to work with. That was fun. Next slide. All right, so I think we don't have to convince anybody on the webinar probably that providing good primary care these days is too much for one person to do a good job of alone. Primary care teams are being developed in some places, but they're difficult to create, they're expensive to create, and they're time consuming to create. And probably they're beyond the capabilities of most small practices. And you could say that even more for primary care teams that are supposed to be part of patient-centered medical homes practices that get recognized for having a so-called patient-centered medical home. So I think that teams and medical homes, conceptually, they hold a lot of promise. They make a lot of sense. And I know there's a lot of enthusiasm for them. The evidence for their effectiveness so far isn't really that strong, except maybe in special settings. Next slide, please. So Teamlets might be an alternative. By Teamlet, I mean a dyad that's one clinician and one staff member that work together most of the time. This term was invented, I think, by Tom Bodenheimer, one of our teammates, probably about 14 years or so ago. And there is a little literature on it of case studies and opinion pieces. The staff member is usually a medical assistant, but can be an RN or an LPN. And I should add that most Teamlet members are not familiar with the term Teamlet. Very few of them, I would assume, are, even though they may be working in what I would call a Teamlet. Unlike teams, Teamlets are simple and quick and inexpensive to create. You can have a Teamlet within a team, or you can have a team that gets created around a Teamlet. Really, almost nothing is known about how common Teamlets are or about how effective they are. Next slide, please. So this was a labor of love for me, really, this project. I was in primary care full-time practice for 20 years, 15 physician-owned practice, 9 of us in primary care, and then 5 after we sold the practice to an academic medical center in California. In those 20 years, I had 3 medical assistants, and really I was very, very close to them. I spent literally a lot more time with them than I did with my wife. My patients knew and trusted them. They knew they were speaking for me, and I trusted them too. Just for an example of the kind of thing that could happen a lot, Susan, my first and terrific medical assistant, would sometimes grab me as I was in the hallway between patients and say, Mr. X just called. And then she'd see me start to roll my eyes, and she'd say, I know that he calls almost every week, but today I just don't like the way he sounds. I think we ought to get him right in here. And I trusted Susan, we get the person right in, and often could avoid an admission or ED visit or something really bad happening. I don't think that happens too often in non-Teamlet settings, and certainly not in large settings. So Tom, Bodenheimer, in an article from 2016, said that Teamlets can transform a large impersonal institution into a small practice environment within which patients know their Teamlet members and the Teamlet partners know their patients. So that's the goal. And how often that happens in a large institution, I'm not sure. Next slide. So our research aims were to identify the prevalence and characteristics of primary care teamlets in the U.S., determine the predictors of physician participation in a teamlet. Not going to talk about that today. We wanted to see if primary care teamlets were associated with less physician burnout and with better quality and lower cost of care. And then we wanted to identify the configurations of characteristics that distinguish high-performing teamlets from other teamlets. Next slide, please. So we did a national we surveyed a national sample of primary care physicians. I'll say a bit more about that in a second. Based on physician responses, we assigned each physician to one of 4 categories. So you could be in a teamlet but not a team. You could be in a teamlet and a team. Could be in a team but not in a teamlet, or you could be in neither, not a teamlet or a team. And again, we assigned the physicians to these categories based on their responses to the survey. The survey was a national random sample of primary care physicians. We used the CarePrecise, I know AHRQ wants to talk a little bit about methods and data. We used the CarePrecise Platinum database, which has the advantage of only costing about $900 and is, as far as we can tell, I've worked with AMA samples and also with, let's just leave it at that. And we haven't found any of these sources to sample from very accurate. We found that almost a third of the physicians that we tried to contact for one reason or another they just couldn't find them, or they didn't meet the criteria for a primary care physician who worked at least 20 hours a week in the office. But we wound up with a decent response rate anyway, and quite a few attributed beneficiaries, about 82,000. Next slide, please. So in our primary analysis, we tested the association between the teamlet and team category, which of those 4 categories, and patient outcomes. We used Medicare claims data for that, and physician burnout, which we measured using a one item from the Mini-Z burnout questionnaire. We included that in the survey. We also interviewed a sample of physicians and staff members to try to identify characteristics of high-performing teamlets. Next slide, please. So these are the findings. I don't have a pointer that I can work with here, but let me just say it verbally. We found that about 77.4% of physicians practiced in teamlets. That was a bit higher than, probably quite a bit higher than I expected. Again, probably very low percentage of these 77% were saying, oh yeah, I work in a teamlet. But functionally, they told us in the survey that there was one staff member who they worked with 80% or more of the time. We used different cutoffs on the percent, but the results didn't change much. Most of the physicians who are in teamlets are not in a team. You can see the 49% versus 28.3%. Relatively few physicians practice in teams, altogether about 36.7%. And a lot of those also had a teamlet. Then there was a pretty low percentage of people who didn't participate in a teamlet or team. That was about 14.1%. So a lot more people, about twice as many people, a little more than twice as many people in teamlets as in teams. And most of those in a teamlet without a team. Next slide, please. This slide's a little complicated looking, but I think I can say it pretty clearly in words. The physicians who were in a teamlet but no team tended to be in physician-owned practices. That's the 56% there. And they tended to be relatively small practices. So about 43.2 plus 41.7, about 85% of teamlet, no team physicians were in relatively small practices. If you wanted to look at people in a teamlet and a team, or people in a team but not a teamlet, they tended to be in larger practices, 3 to 9, or actually quite a bit larger. And they tended to be hospital versus physician owned. So in other words, we see more teams being created in hospital or AMC owned practices than in independent practices, physician owned practices. And then, no teamlet, no team. pretty common in 1 to 2 physician practices and pretty common in physician-owned practices. Not many no teamlet, no teams, only about 27% owned by hospital or AMC. And interestingly, and I don't really have a explanation for this, we found that general internal medicine physicians were less likely to practice in teamlets than primary care physicians, and also less likely to practice in a team or a teamlet, no team. Next slide, please. This is where the disappointment was. I really, based on my own experience of those 3 medical assistants in 20 years, I was really thought that this was a main contributor to quality and lower burnout, but that's not what we found. So these are odds ratios here. The reference group, the group we were comparing all the other 3 categories to, was physicians who weren't in a teamlet or a team. And we found that in terms of burnout, we found that physicians not in a teamlet or in a team had lower odds ratios, statistically significantly lower odds ratios for burnout than any other 3 categories. No teamlet and team, so team without a teamlet, had the highest odds ratio for burnout, most likely to have burnout. We really didn't find any difference in ambulatory sensitive ED visits, which I really thought teamlets would help with. As referenced my story about, I know he calls almost every week, but today I thought we ought to get him right in. I didn't like the way he sounded. You'd think that would help with ambulatory sensitive ED visits, but that's not what we found. And similarly with ambulatory care sensitive hospital admissions, by the way, these are both AHRQ measures that can be used for quality. Again, we didn't find anything really in terms of teamlets, any of the 4 categories improving or reducing the rate of ambulatory sensitive conditions. People who were in a team but no teamlet actually had the highest odds ratio for ambulatory sensitive admissions. And spending, again, was quite a bit higher in all 3 categories. These are Medicare patients, so you could figure maybe 11,000 to 12,000 would be what Medicare would ordinarily spend on a patient a year. So these are pretty large numbers. And we found in all 3 categories really higher spending compared to no teamlet, no team. Next slide, please. Then we tried to look using the survey data in a fairly complex way. We classified teamlets as high, medium, and low collaboration. Kind of came out with a normal curve there, pretty much, in terms of this distribution of high, medium, and low. And we didn't find that outcomes for patients consistently varied based on collaboration teamlet levels or based on the collaboration of the teamlet. We found that perceived collaboration was more likely. Perceived burnout was more likely in the low collaboration teamlets, but it's hard to tell what the causal direction would be in that. Also, if you were in a team but not a teamlet, you're more likely to say that you're burned out. Next slide. So we learned that teamlets were common in practices of all sizes and ownership types. We didn't find strong evidence for better outcomes for patients or less burnout for physicians with teamlets, or really with any teamlet team configuration, whether we looked at a teamlet within a team, a high collaboration teamlet within a team, still really didn't find better things. I didn't note this in the slide, but we also looked at results for dual eligible patients, so Medicaid and Medicare patients who might need more and better care than your average Medicare beneficiary. And we found basically the same null results as we found in our more general analysis. Next slide, please. So future directions could look at the more intensely implemented teamlets improve outcomes and reduce burnout. So Tom Bodenheimer would argue that the average teamlet just doesn't do things that would enable it to live up to its potential. So for example, have your medical assistants do more things. When placing patients in exam rooms, have them review health maintenance and advise patients and the physician of care gaps. Enter orders based on protocols to address the care gaps. That can be done in some states. Do some health coaching. And I think that's it. Next slide. Oh, okay. Yeah. And what kind of research could be done? So do certain types of teamlet team categories achieve higher performance? One could use different outcomes. For example, it'd be nice to measure if we had blood pressure data or hemoglobin A1C, diabetic control data, but we didn't. Use a different method to assess burnout. One could look at, is patient experience better with teamlets? Is staff member experience better? and or is physician or staff turnover lower with teamlets, more interview-based work to explore characteristics of high-performing teamlets. And just to close, there's something called QCA, qualitative comparative analysis, which we used in our second paper we wrote, listed here, and which is, unlike regression analysis, enables you to identify configurations of characteristics as opposed to individual characteristics of high-performing teamlets, and also to use this on relatively small n. Method I would encourage people to look into. Claude Rubinson, one of the authors, is an expert on QCA. Okay, that's it. Thank you.
Thank you, Dr. Casalino. And I love the personal story. Sometimes that's just so much more impactful than what the numbers end up showing. So great work. Okay, now I'd like to introduce the presenter for our third presentation. Dr. Sylvia Hysong will present on the impact of team configuration and team stability on primary care quality. Welcome, Dr. Hysong.
Thank you so much. It's a pleasure to be here and to share the stage with such esteemed colleagues and to be able to share with you some of our team's work. I'd like to start by acknowledging the next slide. I'd like to start by acknowledging the research team and obviously the funding agency which made this research possible. It was a large team and it takes a village. Next slide, please. So just to start with the bottom line up front, by the end of my presentation, I hope to have convinced you that primary care quality can indeed be measured according to and prioritized according to value, that team configuration can be measured unobtrusively through network approaches, that team configuration matters and impacts primary care quality and access, and that the changes to team configurations over time can impact access to care. Next slide. Our study had 3 objectives. So we started by trying to select a set of clear, measurable, accountable primary care metrics, prioritized according to their all contribution and value to primary care. We also wanted to determine which primary care configurations are associated with better access and quality of care. And we also wanted to see whether sort of the stability of the team over time and changes to personnel over time in the team had any kind of impact on quality and access. Next slide. So our study was an observational database review occurring over a period of 24 months. We extracted the records of 22,392 primary care personnel that were drawn from over 7,000 primary care patient-aligned care teams situated at nearly 1,100 VA healthcare facilities from across the country. This is really a unique data set in terms of its size, and because just to give you a sense of its size, so your garden variety study of teams, whether in or outside of healthcare, usually has a sample size, has an average sample size of about 111 teams. So this study at over 7,000 teams, this is a really unique and powerful data set, which makes it sort of a real strength of the study. Next slide, please. To give you a little bit more information sort of about the setup at the VA system, which is where we drew the data from. VA has nearly 1,300 facilities nationwide that are staffed by almost 400,000 employees that take care of over 9 million veterans every year. In the primary care model that's used, that the VA used, is the concept of the patient-aligned care team. So if we look here at the figure on the top right-hand corner, where the laser pointer is pointing, you'll see that the PACT is composed of a primary care provider, an RN care coordinator, an LVN, and a scheduling clerk. That team takes care of a panel of 1,200 patients. And then each one of those nuclear teams, if we point to the figure on the bottom right, also shares some ancillary team members like a pharmacist, a nutritionist, and a social worker. Those are shared by, so every 3 teams, PACtlets, then share sort of these ancillary resources. And that's the recommended configuration in the VA. So for this study, the PACT, the one at the top right, was the one that was the unit of analysis for this study. Next slide, please. Okay, so the first thing we did for the study was to really try to be very strategic about selecting our outcome measures rather than simply just sort of pick what's convenient. Although we did a little bit of that because we worked from existing data sources. But to try to be more strategic and sort of value driven, we used a modified version of a system called PROMES, which is the productivity measurement and enhancement system. Which, as you can see from the slide, it actually does more than just metric selection, but for the purposes of our study, we concentrated on the first 4 steps, which consist of putting together a design team and actually identifying objectives, and then normally generating new metrics or quality indicators. We actually asked our team to select quality indicators from the metrics that we had access to. So for that, we put together a 10-member expert panel that represented relevant key stakeholder groups, including primary care team members, administrators, scientists, patients, and then ran them through the PROMES process so that they could help us select those appropriate metrics from the existing data sources you see on the slide. Next slide, please. And so what we see is that we have the panelists selected metrics along 3 domains of primary care: access, the patient team care relationship, and technical quality. And so for the purposes of our talk today, we're going to focus on access, but do know that the entire catalog is available in the reference that you see on the slide. Next slide, please. Next up was then to calculate predictors of quality and access. And for this, we use the VHA team assignment reports, which is a data source that lists who is assigned to the team at any given time. And then we use the Blau index, degree, team size, and FTE or full-time equivalent, which with the exception of FTE, are characteristics from network analysis to characterize the team's configuration. To be more specific, mathematically, a pack that is configured exactly as I just described earlier will have a degree of 1, a Blau index of 0.75, and a team size and an FTE of 4. So we use those properties and use the average deviation from those properties to calculate a measure of overall adherence to the recommended configuration. Next slide. To look at the question of civility, we then stratify the data set into teams that fell into 1 of 4 categories. Fully stable teams, so in other words, and we're looking specifically here at the RN role. So the same person in the RN role for the entire 24-month period. We had RN vacancy, where the RN role was empty most of the time. Instability, where the role was filled part of the time. And then what I think is the cool bucket is the RN continuous churn, which is where the role was always filled, but not always by the same person. So you were churning through people, even though the data set or the team was technically complete and full the entire time. And so then the bottom set of variables are just some variables that we calculated to put in as covariates in the model. Next slide. We used the multi-level model to look at these questions, and we found a variety of things. So first of all, overall adherence was unrelated to most outcomes. However, when you looked at things a little bit more individually, when you break things down by network characteristics and by individual metrics, the story changes a little bit. In most cases, the 800-pound gorilla in the room was FTE. So generally speaking, teams with a greater number, with a larger full-time equivalence, larger FTE, exhibited better outcomes. In addition, though, we also sort of looked at 2 points in time, right before the pandemic and right before vaccines started to be deployed during the pandemic. And in that case, different team characteristics were associated with different outcomes. And again, sort of there were some differences whether you were looking at before pandemic or during pandemic when COVID started coming out. So for example, role diversity was associated with lower ER and urgent care utilization, but higher patient engagement before the pandemic. We don't see role diversity being associated with much during the pandemic. But we see that teams with higher multiple team membership exhibit lower ER utilization during the pandemic. We also see that larger teams had lower ER utilization during the pandemic, but also lower 2-day post-discharge contact, which is again sort of a measure of continuity and of access. So it was very outcome dependent and very characteristic dependent. Next slide, please. Then in looking at the question of stability over time, what we found was, again, sort of RN staffing instability and vacancy were actually unrelated to any of the access measures. Again, we see that FTE kind of ate up a lot of the variance. So teams with greater FTE over time generally had significantly better access on all of the access measures. But here's what I think is the cool finding. So teams experiencing continuous RN churn had significantly worse access, particularly with third next available appointment time. So this is the group that looks full on paper, but whose RN is constantly changing. And teams with greater overall stability had significantly better scores, unsurprisingly, on third next available, established patient times, and ER utilization. Next slide, please. So obviously we had some limitations, this being archival data, we couldn't really assess any kind of team measure within team interactions. So these data really aren't suitable for any type of team process assessment. So that's definitely an area for expansion, as well as trying to measure the effectiveness of specific network configurations outside of the recommended ones. So maybe a star configuration, or maybe sort of more densely connected or more decentralized. One detail that I neglected to mention about the stability and the insurance was that stable teams. The teams that exhibited more churn were doing significantly worse. But not particular, but you would have expected that the ones that were with high vacancy would have been doing significantly worse than the stable teams, and they weren't. In a weird way, vacancy was its own sort of form of stability, and teams just sort of adapted to the new normal. Next slide, please. And so to sort of conclude and sort of wrap everything, these findings up in a bow a little bit, I think we can conclude that number one, as I said earlier, sort of a targeted set of performance can be curated systematically to track progress towards specific objectives in delivering high quality primary care. We conclude that primary care teams require a minimum amount of FTE capacity to deliver the level of access to care and quality expected of them without danger of clinician burnout and turnover, mainly because what you were seeing in that positive relationship between FTE or size and quality is that the teams with the slower FTE and quality were understaffed. So So you were basically seeing the teams that were sufficiently staffed as recommended in terms of size, versus teams that were understaffed. And that was sort of part of what was going on in that relationship. So suitably staffed and stable teams, specifically the RN role, are associated with improved access to care. And staffing care teams with specific configural features, as we saw, may yield improvements in different aspects of quality of care and access to care. Next slide. Thank you all for listening. I appreciate your time this morning, and I look forward to the discussion.
Thank you very much. Very informative presentation from all three of you. So please make sure you're putting your questions in the chat. I'd like to bring our panelists to full view, and I have a question to start for them, which is, how do you all really envision the results that you shared today being used or implemented at the practice level or the health system level? You know, us as researchers, we love to do the research, but ultimately our big goal is to make some kind of practice or health system change. So how do you envision your results doing that? And Dr. Neprash, I'll start with you.
Sure. It's a great question, and it's definitely the question that we need to be asking. I think that at this point, you know, we're working with data that are a little bit older, 2011 through 2017. At this point, the majority, close to at least, employ of primary care practices are already employing NPs and PAs, and so my hope is that you know, they're kind of the thousand flowers, letting them all bloom and collecting data on them and looking at kind of what the variety is, so that you can understand, you know, what are the different models for kind of collaboration and especially when it comes to access to care. So I think the result I would focus on most in terms of inspiring other health systems would be the convenience of care expansion that we see, which is really driven by not the doctors, right? Driven by the nurse practitioners. And that's what patients prefer. So I hope that health systems see that, and if they're not already, consider offering that if it's in the scope of their clinicians.
That's great. Yes, convenience of care is obviously what patients want. Dr. Casalino, same question to you. How do you envision your results being used in the real world?
Well, I mean, I guess you could say if you were an administrator, you could say, well, we didn't see any benefit to Teamlets, so that question is not relevant, right? But I'm still pretty convinced that if we had other measures, patient experience, patient staff turnover, physician turnover, diabetic A1C control, blood pressure control, I still find it hard to believe we wouldn't find better things. But it may be that the Teamlets, on average, as they currently operate, don't really improve care. I may be wrong, and certainly what our study shows that at least on a gross level, we didn't find improvement in care. So I think practices that want to try this, they first of all could most simply just consciously operate through Teamlets. They're kind of doing it anyway in most practices. Realize that they're doing it. Get familiar with the articles talking about what some places are doing with their Teamlets, and improve what the MA does. There's a lot of simple things that the MA could do that are good for the patients and good for the physicians, good for burnout, but that people think it's illegal for MAs to do. In a lot of states, it isn't. So I'd recommend the AMA's Steps Forward program, AMA Steps Forward, that has a lot of information on things that medical assistants could do to make things better for patients and the physician they work with. And then Tom Bodenheimer's articles on advanced Teamlets, where you have the MAs doing things that a lot of people probably think aren't legal, but actually are. Chris Sinski with the MA has done a lot of work on that. And then positioning the Teamlet within a team more consciously. If you do have teams, or if you want to create teams, how does the Teamlet function within them? So I think those are the kind of things that could be done by someone who wants to do something.
That's great. Dr. Hysong, same question to you.
Certainly. So I think that I think there's several things that, you know, can come out of the study. The first thing is the catalog of primary care metrics. Is there? I only showed a few, but the experts came up with a catalog of 16, plus a few extra that actually haven't been developed yet. And so with a little bit of inspiration for for thinking about how to actually capture the data needed to actually to be able to track to track that metric. So I think that's one place where we can point them, and the idea that they're ordered, right, that they're the rank order in terms of value, in terms of what we should be concentrating on most, versus if you have limited resources, maybe some of them can be put on the back burner. In terms of the actual data analysis of the of the quantitative findings, I think that it's certainly, I mean, the original hope was that we could basically say, this, look, the VA primary care configuration works. We weren't able to definitively say that. But I think that you can indirectly infer that to some extent, because you've got different parts of the elephant are associated with different outcomes, right? So if you think about it sort of from like a Swiss cheese perspective, right? So the teams that so if you've got degree being associated with one set of outcomes, and you've got the role diversity being associated with a different set of outcomes, well, then the teams that actually are doing, are sort of following the recommendation, are sort of plugging more of the holes, if you will. And so that's one potential implication, to think about. But I also think that like I said, I think the finding that was really sort of most interesting to me, that could have some implications, is the question of churn, right? That just because the role is filled doesn't necessarily mean that everything is better, right? Because what's happening, what we suspect is happening, is that every time, right, you get a new person, you need to stop and onboard them and introduce them to the team dynamic and get them up to speed. And number one, that'll slow down your access by definition. And number two, depending on whether that person works out or not, then you've got a potential problem with quality. So the notion that, I mean, we didn't look at burnout in this data set, so we don't know, for example, what the teams that were in vacant mode, what impact that had on, yes, they weren't that different in terms of quality and access, but what happened to burnout, we don't know. So those are all sort of implications, I think, areas that folks in the clinic can maybe concentrate on.
That's great. Yeah, thank you. So before I get to my other questions, I'm actually going to go to some audience questions, because I get time with you guys later. So let me start with Dr. Neprash. I'm going to weave a couple questions together here, but so in your study, you showed what happened when you essentially added a staff member, in this case, a nurse practitioner, to the team. Did you compare hiring a nurse practitioner and the outcomes to hiring a physician? And along those same lines, did you think about including other advanced practice clinicians, such as PAs, in your study?
It's a great question. The short answer is no, but for different reasons. So we were really focused on advanced practice clinicians and the potential of expanding access, motivated by this, the fact that their patient panels on average look different, and different from physicians. So we we didn't look specifically at access expansions when physicians join practices, though we do control for that because we may be seeing some substitution between physicians and nurse practitioners, especially for those small rural practices in our sample. I would love to include PAs in this analysis too. And it's possible that we can, but we weren't sure that we could observe the care they provided quite as accurately as the work of NPs. So that is why they're not in the results that I got to share with you today.
Makes sense. Thank you. Dr. Casalino, one for you. Was there any interest or in any of your other studies, did you look at the care outcome differences in teamlets that used, for example, an RN instead of an MA or another team member instead of an MA?
Yeah, that's a really good question. You know, we thought about doing that, but we had so few RNs that served as the staff member of the teamlet that wasn't worth it. And that's a finding that I didn't mention, but I don't think it's necessarily a surprising problem, surprising finding. The MAs were overwhelmingly the most common staff member. RNs for most practices just too expensive to devote one RN 80% or more time to one physician. It's different from a team structure where you might have one RN serving, several physicians, say. But again, that's different from the how we define teamlets.
Thank you. Makes sense. And that kind of leads into an audience question that was directed at Dr. Hysong, but Dr. Casalino, you can also chime in. So your study, Dr. Hysong, showed differences when you had a team. And obviously a team is different than a teamlet. But what do you think? What do you hypothesize might help explain the differences in the impact of teams on outcomes in your study versus Dr. Casalino's study, where we really didn't see any outcome differences?
Sure. So a couple of things. It's actually kind of interesting, sort of the question of nomenclature, because at least in the VA system, the small, right, the 1, 1, 1, and 1 is referred to as a teamlet. So we call that a teamlet over there, and it's really sort of the packed is sort of the neighborhood of 3 right packed teamlets and their resources. But I think that I think that Dr. Casalino's study and my study in looking at the specific, nucleus, I think that's sort of the comparable team structure. And so sort of the thing that came to my mind, and I think I sort of alluded to this, I posted a question in the chat forum. I'm wondering how people implemented the transition, right? In the VA system, this was a national implementation, right? So basically, the powers that be at the top of the VA said, "Thou shalt implement teams." And so a lot of resources were put out all at the same time to transition everybody to a team structure. Interestingly, though, it was what I think was really interesting, and part of the reason why we were able to do the study is because only 20% of teams in the VA look like the recommended configuration, right? So in other words, individual facilities had quite a bit of leeway in how they were going to actually make that recommended configuration of 3 to 1. In other words, 3 care teams members supporting a physician per panel look like. So that's probably where my brain would go to in terms of like that. I would go into like, how did the transition actually happen?
Yeah, it's a good question. Dr. Casalino, did you have any indication in your data about how these transformations happened?
No, we didn't. But I would just say in response to your question, Yalda, I think, first of all, we're not comparing teamlets to teamlets here, right? Secondly, VA is a special setting, right? And thirdly, I'm not sure that we have directly comparable outcomes, or not at least very much. So from that point of view, it's something worth thinking about more. But I'm not sure how much the two studies can be compared, really.
Yeah, great points. All right, Dr. Neprash, I'm going to pepper you with a couple questions here because I think they won't take as long, and there's a lot in here. How does the all-payer data account for the uninsured population?
I love a nitty-gritty data question, so thank you for that. Anybody without insurance shows up as self-pay. So the key here is that we have the records that Athena Health keeps for medical billing purposes, rather than the claims as they are paid by an insurance company. Where you're right, if there's no insurance company paying them, you wouldn't see that. But because we see the actual billing records for the practice, we can also see the patients who are assessed the cost of the full cost of their care.
And then one more, that makes sense. Did your data in any way show how many, because you talked about how convenience care was kind of the biggest finding, right? How many clinics changed or added an urgent care model instead of keeping the model that they had before? Could you tell?
Unfortunately, I don't think I can observe something like that. And maybe I would love to talk offline to the participant who asked that question. But I don't think I have access to a large change in model scope like that.
Okay, makes sense.
Thank you.
Dr. Casalino, you mentioned a little bit about a qualitative comparative analysis paper in your presentation. Could you dig in a little bit about what the results were from that?
Yeah, I don't think we found any results that were super striking, and I'm not sure it's worth taking time on. I do want to emphasize again, though, that if you're a person who, let me say just one more thing about QCA, which I think is a really good method. It uses a kind of quantitative techniques, but it works well even with relatively small n. And I just want to emphasize the difference with regular regression analysis like we used in our main paper. So in regression analysis, you can find if there's possible predictors of an outcome, A, B, C, D, and E, you can find out is A significantly associated with the outcome, is B significantly associated, and so on and so forth. QCA is aimed at saying the high performing team would say, ideally, this would be the kind of finding you would get. You're a high performance teamlet if you have A and C, or if you have B, E, and F, but not otherwise. And so then you can look for, because in the real world, it's configurations of things that make things happen, not not individual, not the statistical significance of individual variables. So it is a method that's worth looking at. It's being used more in health services research, and I would encourage people to think about that if they intend to include any kind of qualitative work in their study.
That's great. Thank you for that. Dr. Hysong, a couple of nitty-gritty questions for you. Number one, can you remind us of the name of the catalog that you were referring to in your study? And number two, how can someone go about getting the data set that you used for your study?
Sure. So in terms of the catalog per se is actually in a PLOS One 2021-22 study. It's in the references list of the slides. But the process that was used to generate the list is called PROMES, which is Productivity Measurement and Enhancement System. It was a method developed by Bob Pritchard in the 90s. So it's been around for a while. It's been used in a variety of different settings. And it's what I find cool about it is that it really forces you to think about, right? Sort of it's in a way it forces you to be explicit and verbal about what you value, right? Is getting patients in the door more important than than telehealth appointments or something like that? And it forces you to really sort of think about quite strictly about those decisions. In terms of where to get access to the data set, that is a VA data set. So the short answer is buddy up with a VA investigator who can help you achieve access or gain access to to those VA data sources, because they are behind the VA firewall.
That's great. All right. Thank you for that. And I know we're coming to the end. Dr. Neprash, I have one more question for you. Were you able to look for any variance correlated with the length of time the NP had been in practice, thinking that a more experienced NP might have a higher rate of productivity and independence?
Yeah, that I liked that question a lot. And I don't necessarily know of any database that would have length of practice. And because we're looking specifically at, the first, NPs who were being hired in the first, less than year of their hiring, we definitely have a range of everybody who's fresh out of school through, seasoned professionals. And I'm sure there's variation in how quickly they adjust to a practice. I have a couple of thoughts, and I put them in the chat about how to kind of get at this tenure in practice rather than or tenure in medicine rather than at the practice itself. Maybe from some public databases, but that is something I will be taking away from this webinar as a really good suggestion.
And we have someone who suggests looking at state licensure databases, and that will help the length of practice.
Thank you.
Well, thank you all for this really great presentation. I know I learned a lot, and I bet everyone tuning in did. So we really appreciate you taking the time, sharing your research with us, and good luck with all your future directions in your research. Thank you.
A pleasure.